Ladies and gentlemen, welcome to the Strategies for Reducing Antipsychotics, a Consultant Pharmacist Perspective conference call. Your host for today is Kathleen Lavich. You may now begin.
Good afternoon. This is Kathleen Lavich. I'm one of the nurses on the nursing home team at EMSO. Welcome to today's webinar presented by the Lake Superior Quality Innovation Network. The Lake Superior QIN is comprised of three organizations: EMPRO in Michigan, Metastar in Wisconsin, and Stratus Health in Minnesota. And we support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. We will have time at the end of this webinar for questions and answers, and you can also put your questions into chat at any time. I would like to introduce our speaker for today. Derek Sanders, Doctor of Pharmacy, is the lead consultant pharmacist for the Southwest region at Remedy Senior Care. At this time, I would like to turn it over to Derek.
Thank you, Kathleen. Good afternoon, everybody. This is a pretty in-depth topic. I think it's important to know kind of how consultant pharmacists in the field are, dealing with reducing antipsychotics, and we'll kind of look at that from what I experience on a daily basis in some facilities. So on the next slide, we're going to start out with a case study, and it should be when we start looking at the details, some of it should be a little familiar about what the diagnoses are. It's going to be a typical resident that you would see on admit to a facility. Next slide, please. We have a 92-year-old female. We have dementia, depression, hypertension, hypothyroidism, history of falls, hard of hearing. And so, this is typically what our residents look like that are admitted to a facility, whether it's after a fall for skilled care or even a long-term care admission. This is going to be a typical resident that you would interact with in a facility. Next slide, please. If you look at the nursing note on June 17th, 2010, there's increased confusion today. Bed and chair alarms on due to fall risk. Despite alarms, resident found on floor and bathroom with stool and diaper. States she is getting ready to go to a wedding. Doctor's contacted. He gives some orders. Stools times 3. He's checking for C. diff. Things must have not. There may have been some contact with the physician about the smell. He goes ahead and hits it with Flagyl. Going to start off on an antibiotic to head off C. diff if it's there. But he also adds Haldol 5 milligrams now, and then every 12 hours as needed. Next slide. PRN order is placed into the record. 9 p.m. Haldol is administered. Should be no surprise to you at 10:30. Residents snoozing away. We would expect that after getting a 5 milligram dose of Haldol. Next slide. So we've got June 23rd, 2010 at 10 p.m., 6 days after the initial order for PRN Haldol. Nursing note states resident expressed that she wanted to go to Kmart to buy nylons and a raincoat for a roommate. She's calm but confused. Regardless, there was another PRN Haldol given. And guess what? It was effective. The resident stopped preparing to go to Kmart. And so, And these are actual nurses' notes from this case study. So just kind of keep that in mind. Next slide. So we've got July 19th, 2010 at 12:10 a.m. This is one month post, order. We get another nursing note. PRN Haldols given for agitation. There's no description given in the nurse's notes, but it does say effective results noted. I would assume that what those effective results were was resident sleeping. And so that would be probably my guess, that resident went to sleep and that was effective. Next slide. We get our consultant pharmacist that comes through July 20th, 2010. Pharmacist medication regimen review, and he says no irregularities noted. Next slide. August 2nd, 2010 at 10:30. We're about 6 weeks post order. We get another nursing note, resident agitated. Again, we don't have any type of a description of, what are they doing? What agitation? I mean, are they slapping their neighbor? Are they throwing things around the room? We have no descriptors here. So another PRN Haldols given, and residents now sleeping. So it was effective. Next slide. Nursing note, August 2nd, 2010 at 4:45, nursing assistant reported that resident was packing up her room to go home. Resident requested shopping bag to give pictures on windowsill to the person they belong to. PRN Haldols given, and it was effective. Resident no longer wants to go home. So here's your second dose of Haldol, 5 milligrams. It's administered less than 24 hours. Next slide. So August 2nd at 6:30, 2 hours after the second dose, we get a nurse's note that says resident has muscle spasms of the neck, clenching of teeth. This is a new finding. So we've got some extrapyramidal symptoms due to the antipsychotic going on. So now things have gotten a little different as far as, we don't have agitation, but now we have some issues with the administration of an antipsychotic. Next slide. It should always be, when there's a problem or there are new changes of condition in a facility, one of the things I always relay to my facilities is, look at the meds. Let's look at the medications first. Let's look at what has been changed, and it's a good starting step. So just like this comment here, which has been included in a lot of the training with CMS and for surveyors, any symptom in an elderly patient should be considered a drug side effect until proved otherwise. It's a great starting point, and you should. That's where you should start first, looking at side effects of drugs and seeing, if that is where it's at. So it's always good to keep in mind if you see any changes of condition, we want to look at those medications first. Next slide. So August 2nd, 2010, here we are 2 hours after the second dose. Resident, they had these extrapyramidal symptoms, so the doctors called, Haldol discontinued, although I don't like Benadryl. This is the case that you're probably going to have to use something like Benadryl to help with these symptoms. So Benadryl has its own issues in the elderly too, but you're going to have to use something like this in order to help with this. Next slide. So August 3rd, 2010, approximately 6 weeks post-order, seen by the doctor, ordered Cogentin for cogwheeling and dyskinesia. The symptoms resolved within 24 hours. So doctor comes in, kind of gets everything under control. Next slide. So we need to review let's review like the indications all through this case study. You kind of see a trend. June 17th, confused, falls in the bathroom, wants to go to a wedding. June 23rd, wanted to go to Kmart. July 19th and August 2nd, agitation with no descriptors on both of those instances. And August 2nd, wanted to go home. Nothing in here is a valid indication for administering Haldol. And so it's good to look at this and really look at the nurse's notes and just look at it and say, where were the problems here as far as, what was the indication for giving an antipsychotic? Next slide. One of the things you're going to have a hard time doing as a consultant is ever getting me to believe or a surveyor to believe that, like in this case, that a PRN antipsychotic was necessary. So it's important to know, and it's important that your consultant pharmacist, anytime they see a PRN antipsychotic, that's going to be what you'd call low-hanging fruit. We're going to really jump on that pretty quick. But there really should never, that's always going to be viewed as a chemical restraint on a PRN antipsychotic. And I can't argue with that. There's not going to be any surveyors that you're going to have a hard time ever explaining that. So unnecessary drugs, there weren't adequate indications for use for this. Were the doses excessive? Probably, just because of, there wasn't an adequate indication for it. So the dose would be excessive for what they were treating. So the nurses knew or should have known how that was not indicated. Drug regimen review, we didn't find any drug irregularities when the consultant came in. So there were some failures on a lot of different areas here. So next slide. So in this case, in this facility, there was a directed plan of correction, and then there was a penalty of $10,000. So these types of things, instances, they do happen, and there is money involved. I think it's always good. I don't see in the past, I have seen cases that look a lot like this in Oklahoma. I can tell you now that over the years they have diminished, and you may not see these as much as other areas of the country. But I will tell you they're still out there sometimes, that you will occasionally get a physician that will put somebody on a PRN antipsychotic or prescribe something when there's really no indication for it. And so we need to be aware of it. So it's always good to look back because everything's cyclical. It kind of comes back. So you always got to be prepared for it. Next slide. So could some or all aspects of this case happen in your facility? I hope some of them don't, but I think some of the documentation type things probably happen in everybody's facility, and there's other reasons for that. I do look at nurses' notes, and I see a lot of times, you see patient is agitated. We really need clear descriptors. We need to know what they're doing. Are they slapping their neighbor, or are they throwing items? Are they, what type of, we really need to know, what they're doing. What is the behavior? So, another thing that you might see happening in your facility, on the documentation, front is just because, I see this a lot in facilities is, I'll call her Mary Lou, or whoever the resident is, throws her fork every day at Billy across the dining room. There's a lot of times, because it's normal for her to do it, there's no documentation of it. If you see people that have behaviors that are common, they typically will not be documented in the resident record. So it's important that your staff, just because it's normal for that person, all behaviors need to be documented, and they need to be described what's going on. And we'll talk a little bit about that as we go into these other slides. Next slide. So we really need to define the issue here on the condition of the behavioral and psychological symptoms of dementia, or BPSD. You do have agitation. You have anxiety, irritability, depression, apathy, delusions, hallucinations, sleep or appetite changes. It's one of those, a lot of times people will say, wow, they're just getting older. And yeah, I think sometimes it is part of getting older, but a lot of times there are explanations for a lot of these symptoms, but you will have this in people with dementia, and they will exhibit these symptoms. So it's always, you see this in your facilities, and you see it on a daily basis. Next slide. One of the things when you talk about treating some of these, treating these symptoms of the behavioral and psychological symptoms of dementia, when you're treating these symptoms, you don't have to look very far about some of the behaviors that residents at facilities have with dementia. It's a lot like kids, and a lot of times you really have to look at, things that they're doing and think, I always think to myself, we're treating some of these people with antipsychotics, and it's no different than, their behavior is no different than some of these depicted on the screen. So it's something to think about. I think a lot of times we're guilty of throwing drugs at a problem, and I hope that consultant pharmacists are helping in that area, helping limit that sort of practice. But I do think a lot of times we do throw a med at a problem sometimes. So next slide. If you look at this graph, and I don't want you to really take anything away from this graph other than the next couple of graphs. I don't want you to really take a whole lot from it besides if you look at where the nursing home placement is, I just want to make sure you come away on these next two graphs that you see most of the time when they're admitted, we're getting them when they're either at the upper end of moderate to severe Alzheimer's. So you're getting them when family can't help, the family is at their wit's end, the behaviors have gotten to such an extent that they can't manage it. And so you are getting them as the disease process has really gotten to the high moderate to severe phase. And so what these graphs will show you, go ahead and go to the next slide. What they will show you is that as a facility or in your facilities, you've got to be prepared. We have to have processes set up to handle some of this. So, because we're getting them when they come in and they're having some of this aggression, delusions, socially unacceptable behavior, irritability, things like that, sexually inappropriate behavior. So they're coming in to the nursing homes in this area towards the severe stage of the progression of this disease. So we've got to be, prepared, and our staff has to be prepared to help. Next slide. One of the things, and this is one thing that everybody needs to know, and I don't care if it's the person who is housekeeping or I don't care, really who it is. Everybody needs to know that, these people aren't behaving this way just because that's who they are. A lot of times, most of the time, I would say behaviors, it's a form of communication. It's a form of I'm hurting. It could be I'm bored. It could be, I need to be changed or, whatever the case may be. But it is a form of communication, and it's important for all of your staff, from nursing to housekeepers to everybody, to understand that, these behaviors, aren't, they're a communication tool for the resident, that otherwise, he could just tell you, or he or she could tell you, that they just don't have those skills like they used to because of the disease process. Next slide. The other thing we need to look at is the drugs, and you should recognize some of these drugs, your antipsychotics, Seroquel, Risperdal, Zyprexa, and, do these have a place? Yes, they have a place. They are indicated for certain things, certain disease states, and they are good for those indications. What we're getting into a lot of times, though, is like from the case study, when they're used for invalid indication, then that's where we get some of these issues come up. Next slide. So, a lot of times you'll talk to people and they'll say, oh, doctors use off-label drugs all the time, but, it's kind of a slippery slope there. There's, for an appropriate off-label use, you do have certain safety plus efficacy measures. And, I have met physicians that would say, hey, I think it helps. I will tell you, as we look at the side effects of meds, of these antipsychotics, it doesn't make a whole lot of sense to me to, if you remember back to the case study, this lady fell. She was a fall risk already, and then we gave her Haldol, which is an even greater. It made her more of a fall risk. So, and then she was having cognitive issues as well, and so we decreased her cognitive ability by adding a highly anticholinergic type medication to her. So it's hard to convince me in those individuals and those instances that antipsychotic's the right choice. So, and so when you see people talk about off-label, yes, do doctors use things off-label? Yes, they do, but there has to be a little bit of a balance between efficacy and safety in order for it to be appropriate. Next slide. And you guys are all aware that the black box warning for antipsychotics in elderly patients with dementia, that's, everybody should be, very aware of that because we've really hit that hard as a country. I do see it, I think it's kind of, after the first year of targeting antipsychotics and reducing them, you're kind of seeing them come back up a little bit. I know in Oklahoma there are some trends on upward trend. I haven't seen it in the facilities that I visit, but as a state, I've been talked to about it by state leaders that our percentages of antipsychotic usage in our elderly residents has increased a little bit back to those numbers prior to the initiative. So this should not be a surprise to everybody. I mean, it has a black box warning. Next slide. So this is just a graph talking about, where it was in the journal of the JAMA Psychiatry reference and or journal, and basically the lower the number, the riskier the drug. It shouldn't surprise you, Haldol's right up there. Risperdal, Zyprexa, Seroquel, and your antidepressants, and they just basically looked at psychotropic agents. And so when you see the number 26, basically all that means is that 1 in 26 older patients would be expected to die within 6 months of starting Haldol. And it just goes on from there. So Risperdal 1 in 27, Zyprexa 1 in 40, Seroquel 1 in 50. And then your antidepressants, 1 in 166. Next slide. So adverse effects of antipsychotics, you're going to have weight gain, drowsiness, dizziness. You do have, blurred vision, constipation, tremors, restlessness, persistent muscle spasms, possibly rigidity. It can increase your blood sugar. Anybody that's kind of a borderline diabetic, it could push you into diabetes. So, I mean, they have some bad adverse effects, okay? And nobody's denying that. But it's good to look at them, because some of these you look at, and before we even start them in an elderly person, they're already having issues with these things already. So, they already have dry mouth, they already have constipation, they already have restlessness. So, what we're doing is we're throwing a drug at something to prevent a behavior, but we're causing more problems than we're treating, basically. Next slide. And we're not alone. I mean, everybody understands. You'll see some of these comments from the American Psychiatric Association, the American Geriatric Society. Everybody's in agreement that antipsychotic medications are probably not the best route to treat, dementia residents. And so, and they also, know that you have to have basically a valid indication to use these type of medications for a person. And so, this is, everybody's in agreement that takes care of geriatric patients. Next slide. So here's kind of a brief on the nursing home regulations, talking about residents, kind of basically the regs on antipsychotics. You should have, in your facilities, you should have some sort of process where you are reviewing these. Your consultant pharmacist is coming in and making recommendations about gradual dose reductions. You should have a process in place when there's a new admit and it's somebody who doesn't require a PASR, and they come in on a antipsychotic. They're taking it, within a 2-week period. You are addressing and evaluating that antipsychotic regimen while they're on it. And so it's a good thing to have these regulations, but you've got to have the processes in place. And you also have to have, like we were looking at earlier, when you get these individuals, when they're admitted to your facilities, you've got to have some processes set up for these behavioral interventions. So they're already having behaviors when you get a dementia resident. So you're going to have to have those things already set up. So next slide. One of the questions I always get, and this is what I always talk about, is when I go into a facility, I notice somebody's on a antipsychotic, and I ask about the behaviors. What are the behaviors? And, typically who I talk to is the people who touch them and help them the most. And that would be my CNAs in a facility. They're with them all the time. And so you get some real good information as far as behaviors when you're talking to people that are actually touching them, seeing them every day, seeing them at all different times of the day. And so it's always good to, you can talk to the nurse, and the nurses will have some good information, but your CNAs and a lot of times your CMAs are going to have a different outlook about what the behavior is and how severe it is. Because typically the nurse may know about it, but they may have not witnessed it firsthand. So it's always good to go to the person, that has hands on them all the time. So a lot of times people ask me who can report behaviors, and whose responsibility is it? The answer to that is everybody. Everybody's responsibility. It's everybody's responsibility that works in that facility, and anybody can report a behavior. It could be your housekeeper if they see a behavior. It could be your CMA. It could be your activities person. It could be anybody. But they do need to know if they do see a behavior and they report it, there's information we need. Next slide. So, this is one thing that I preach to my facilities is what do we need to know about a behavior? What information do we need to know? One, we need to know, what was the behavior? Were they throwing things, hitting, spitting, whatever it is. Have them describe it. What time of day was it? Where was the location in the facility where they observed the behavior taking place? Residents or staff members present during the behavior? Any environmental issues noticed that could have contributed to the behavior? One of the things, I don't know if you've ever been around during shift change at a nurse's station, but it's extremely loud. There's a lot of activity. And so a lot of times if your dementia residents are in that area, they're just overwhelmed by this noise, and you can see behaviors happen at those times. So it's always important to look at some of this and to basically pool all this information when there is a behavior reported and use your interdisciplinary team to kind of get a plan together to help with interventions for the behavior. Next slide. And always, the last one, we always need the nursing staff to complete a physical assessment of the resident. We always want to rule out medical. Is there a medical reason this behavior is taking place? So that's the number one thing. Once a behavior is identified or being reported, nursing staff has to get that done. Make sure you're ruling out any type of medical involvement. Next slide. So the interdisciplinary team responsibilities, reviewing reported behaviors and developing behavioral intervention plans. It's always important to encourage family with a power of attorney or whoever's in charge of their decision making. And you always have to look at the resident and find out about their past. I mean, what kind of career they were involved in, what kind of hobbies. Those can give you keys on what you need to do as far as developing their behavioral intervention plans so you can redirect them effectively. Reviewing newly admitted residents to the facility that have current antipsychotic therapy. A lot of times what we run into is antipsychotics that are started in the hospital, and they weren't on them prior to entering the hospital. If you have a dementia resident that's admitted to the hospital, they're going to have behaviors. And unfortunately, a lot of times, there's going to be an antipsychotic prescribed because they don't want them getting out of bed in the hospital. So we really need to be aggressive about when we see an antipsychotic on a person we're admitting to our facility, that we really drill down and figure out, one, what's the indication for this medication, and two, were they on this prior to hospitalization? I mean, where did it come from? And so we're going to have to really talk to the family about that. And that's how we would kind of figure out where we need to go from there. Next slide. Here's some of the interventions addressing aggression and agitation and dementia. There's a lot of different things that you can use, from music therapy. We have quite a few facilities in Oklahoma that are doing the music therapy, and it's done well. We've had residents that are, involved with this, and especially when before their family visits, a lot of times, they can put these headphones on and listen to this music from their era when they were younger, and it helps them. It helps them. There's something about music that really gets people, it calms them down, their cognitive level is better, and so it is really, I think there's a lot of good things and good results that have come out of the music therapy. Structured activities, dancing, exercise, that all goes into, that has helped. And so, you know, I'm big on the music therapy just because I've seen it firsthand, and it's really done a lot of good things. You know, it could be, you could use things like photo books, photos of family. People can do that. I've seen people that used to be carpenters, and they will, you know, have a tool area for them to go, and they can mess with a few tools like a wrench and things like that on some nuts. And I've seen that in some dementia care units. But and it doesn't have to be one of these, depending on what it really is. It should be individually, you know, it should be based on that individual. Next slide. One of the things that we've got to be careful of, and this is one thing that I do as a consultant pharmacist, is I've seen it too often, but you know, we really need to wean, if they've been on an antipsychotic. I know we want to get them off, but I've seen it too often that instead of weaning somebody off, the physician will just discontinue it altogether. And what happens is we get this effect of we get the opposite effect. They start having behaviors because we've taken it off and we didn't wean it. And that is a problem. And so what you'll have a lot of times is, oh, they failed the dose reduction. Well, it wasn't really they failed the dose reduction. It's that we didn't appropriately wean off the medication. And so they were having side effects due to the withdrawals, basically. So, you know, if they're not weaned appropriately, you know, you could have withdrawal issues with behavioral outbursts, and then we're going to start the antipsychotic back. And, you know, so we don't want to do that. You know, I always tell people go slow. It's not a marathon. It's a marathon. It's not a sprint. And I don't care how long it takes me. It may take me a month. It may take me a month and a half to get them off of the medication. But the ultimate goal is discontinuation. You know, we don't need to be afraid to question, you know, an antipsychotic, you know, why was it started? You know, I think it's always, if you don't have a valid indication, it's always good, but to ask that question, why are we starting this? You know, we're an advocate for the residents in our facilities. And I hope your consultant pharmacist reaches out to you and says, you know, if he sees an antipsychotic started, you know, I'm hoping that he, you know, ask a lot of questions about why this is being started. It's also very good to keep your medical director and your physicians involved with your goals of reducing these and discontinuing antipsychotic medications. I'm not going to tell you that there isn't times that, you know, there are times that you have to use antipsychotics. But what we need to do, if we do have to use them, we want to use the lowest dose possible. And so that may take a little time to figure out what that dose is, but it's vital to do that and work with your medical director and the physicians at your facility to make sure we are doing that. And that is all I have for this presentation, and I can take questions.
Okay, thank you so much, Derek. This is very valuable information for all of us. Operator, would you please now open the lines for questions? Okay, while we're waiting for questions, there's one that was put into chat. Derek, are there any diagnoses that are acceptable to prescribe antipsychotic meds for outside of Huntington's, Tourette's, or schizophrenia? Would schizoaffective disorder apply?
Yes, it would. It would apply. it's going to fall in the same arena as, but that would be a valid indication. Bipolar disorder is going to be a valid indication. There are times that people with dementia, after all the behavioral interventions have failed, and there's not a medical cause for this behavior, if they're a danger to themselves or somebody else, you may have to use an antipsychotic. But the thing is, we're going to have to review that all the time and make sure that it's needed. But yeah, schizoaffective disorder would be a valid indication.
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your telephone keypad. Once again, if you have any questions, please press the number 1 key at this time. Our first question comes from Jesse. Please go ahead.
What are some reasons that a GDR is clinically contraindicated?
What I would say on a dose reduction being contraindicated, typically if you have history in the resident record or information that a reduction is tried in the past and that person has, acted out or had some behavior that was harmful to somebody else or themselves, then that would be when something would be clinically contraindicated. If there's symptoms, if reducing that medication will increase their symptoms, which will then in turn decrease their quality of life, that is when something would be clinically contraindicated.
Derek, this is Kathleen. Isn't it important, too, that the physician makes sure and documents very well why the gradual dose reduction is contraindicated in a resident, including what behavioral interventions have been tried and failed, as well as what gradual medication, gradual dose reductions have been tried and failed?
Right. Yeah, we're always going to have, the documentation is where it's going to, that's always where we're at with the GDRs and the clinical contraindications. You're going to have that documentation in place to be able to prove that you've done what you need to do to prove that it's clinically contraindicated.
Yeah. Okay. Thank you.
Mm-hmm. Our next question comes from Sarah. Please go ahead.
I was just wondering how long is there? I know that there's no exact time frame of how long they have to use psychotic medication. They're working in behavioral health. I was wondering if we did start to do the long-term care on a new antipsychotic, do they have to discontinue that medication? I know they demanded.
Kathleen, did you get that? I didn't hear all of it.
I did not. I'm sorry, Sarah. You were really breaking up a lot. Did you repeat your question, please? Did you put...
Six charges from an acute behavioral health inpatient unit to a long-term care facility. How long do they have that new antipsychotic on board?
Okay, Derek, Derek, looks like you also put that question into chat. But it says, if a patient is admitted from a behavioral health unit to long-term care on a new antipsychotic, how long do you have to discontinue the medication per regulation?
what I will tell you is, and this is my experience in Oklahoma. Okay, that and this is kind of where I lead to. I'm not going to tell you that just because they went to a behavioral health unit and were started on an antipsychotic that they had a valid indication for start. I'm just being brutally honest. But what I will tell you is that when they come into the facility, they're admitted. I will have that facility within the first couple of weeks review with the medical director of, hey, why are we on this? What's the indication? Okay, and what were the behaviors? Were they? Because we have to identify, what are the behaviors we're treating? What's the indication? The other thing is that are they harmful? Are they harmful to themselves or others? Okay, and so within that first couple of weeks, regulatory-wise, you probably should be doing something within that first couple of weeks, but definitely within that first quarter, you've addressed it. And so if they don't require a PASSAR, regulatory-wise, you have 2 weeks to evaluate it. But if they do have a PASSAR, my facility, we're doing it in that first quarter. If they have any type of dementia-related diagnosis, we're looking at it quarterly. So, but you got to be careful with, like I was saying, when we go to discontinuing meds, it's a long process. It's not quick because I don't want to get them into where they're withdrawing and they have behaviors and then we're back to square one. So.
Okay.
Our next question comes from David. Please go ahead.
Hi, how are you doing there?
It's open.
Okay. Good question. As far as the antidepressants are concerned and that patients with dementia black box warning, are one preferential over the others as far as recommending an antidepressant, like the SSRIs or SNRIs and so on and so forth?
I would lean towards the SSRIs. I would. And, typically what you will see, Lexapro, Celexa seem to be probably your better choices. Just, that's typical. Prozac's never a good choice just because of it has a high incidence of anorexia. So their appetite typically will be blunted somewhat. So Prozac's real stimulating, so you'll have sleep issues a lot of times too. So Prozac's usually off the table. But typically you're going to go with Lexapro, things like that.
We have no further questions in the queue at this time.
Okay, Derek, we have a couple more that have been typed in the chat. Do antipsychotics ever work for delirium?
Do they work?
That's the question here.
Okay, hold on. They do work for delirium. I will tell you this, that you have to be really careful about. If that's your indication, delirium it doesn't last. There's a reason they have delirium. So my experience with people using an antipsychotic for delirium, it's never going to be long term because what's the delirium from? Is it due to infection? When that infection is done, then that antipsychotic should be able to be reduced and be gone. But for delirium, yes, I mean, the antipsychotic's effective. It just can't be used long term because that delirium's going to go away.
Thank you. Another question we have, Garrett, do you have any recommendations for strategies to use if the consultant pharmacist recommends a dose reduction and the physician provider disagrees?
Typically what I will do is if it happens not to be the medical director, I have had meetings with medical directors to kind of help me with that. But typically I usually have a meeting with the DON and the medical director if I can get one scheduled and just discuss with them, why we're doing what we are doing, why we want to limit the amount of antipsychotic usage. But that's typically what I will do. And I usually will ask for the medical director's help, with other physicians to try to get everybody on board.
Excellent. Okay, and one more that we have, what are your feelings towards a hospice patient using antipsychotics?
I will tell you that I am not opposed to antipsychotic usage at end of life. I think there are times that I'm not opposed to it because I feel like that there are instances where you can have people that are going through the dying process that it helps. It helps them. It's more of a comfort measure than anything. And so I'm not opposed to it in end of life at all.
All right, thank you. And one more question we have time for. Which antipsychotics are best for dementia residents in terms of causing the least amount of side effects? Haldol's always going to be the worst choice just because they're all the first generation type antipsychotics. Your second generation antipsychotics like Risperdal, Zyprexa, Abilify, those are your drugs that have least amount of, you're still going to have issues as far as, you can have weight gain. That's all going to be there. The only difference is you have probably a less amount, your risk of having the extrapyramidal symptoms or the abnormal, involuntary movements is less with the second generation antipsychotics. But those agents will still have all of the side effects we saw on the slide as the first generation. Okay. Very good. Thank you, Derek. I think that's all the questions. If there's any more questions in the queue? No?
Oh.
Okay.
No more questions in the queue at this time.
No more? Okay. So thank you for joining us today for the webinar. And we do have an evaluation up on your screen. We would like to ask you to please complete so we know how we are doing. Again, thank you so much, Derek. It's been a wonderful presentation, and you've given us a lot of information. Thank you so much.
Thank you.
Ladies and gentlemen, this concludes your call. You may all disconnect at this time.